for, it's my great pleasure to welcome our presenter, Vidanka Vasilevski. I would like to share a brief update before we begin. Professor Linda Sweet is unfortunately unwell and unable to join us to present today. Linda has made a significant contribution to this work, and we acknowledge her leadership and long-standing commitment to advancing midwifery practice and research. Dr. Vidanka Vasilevski is a senior research fellow in the Deakin University School of Nursing and Midwifery and Western Health Partnership in Melbourne, Australia. Vidanka's work focuses on the socio-demographic factors and maternity care models influencing pregnancy outcomes and quality of maternity care. Welcome, Vidanka, and thank you so much for joining us today. I will now hand over to you.
Thanks for that introduction, Kristy, and thanks to Vidam for accepting our presentation today. I'd like to acknowledge Linda's input into this presentation, and unfortunately she can't be here today, but I'm sure she's here with us in spirit. So today I'll be presenting on implementing midwifery antenatal postnatal services. They're known as MAPS, to retain midwives and improve access to continuity of care. And I'd also like to acknowledge all my co-authors that are listed there that have played an important role in this project. So I'd like to acknowledge the traditional owners of the land from where I'm presenting from today. They are the Wurundjeri people of the Kulin Nation, just in that little orange section above the red arrow. And I'd like to pay my respects to their elders past, present, and emerging. And I'd also like to extend my acknowledgement to anyone who might be watching this presentation. So just to give a bit of background, we know that midwifery-led continuity models of care have benefits for both women and midwives. There are challenges in implementing and staffing continuity of models because they require a great amount of resourcing, as well as there has been some reports to suggest that midwives find a lack of flexibility due to the need to be on call as a reason as to why they find it difficult to work in these models, even though that they wish to. A recent Midwifery Futures report from Australia showed that 1/3 of Australian midwives are leaving the profession due to burnout and lack of work satisfaction. And this is something that's consistent globally with a great strain on the midwifery workforce because of staffing related shortages. So it's important that we invest in models of care to retain midwives and improve access to continuity of care for women because we know it has the best outcomes for them. So midwifery continuity of care models such as midwifery group practice are a model of care where women receive care from a node midwife across the perinatal continuum. And these models are valued because they use the midwife's full scope of practice. However, as I said before, sometimes midwives cannot work in them due to lack of flexibility, particularly if they have young families or other commitments such as caring for older parents or if they're doing additional study. And midwifery antenatal postnatal services, or MAPS, have been developed in order to address this issue where women receive continuity antenatally and postnatally. However, labour and birth care is provided by the standard maternity service. So in this instance, the midwife does not need to be on call for labour and birth, but still allows her or him to have have the woman and both the midwife to experience continuity, which is valued by both parties. MAPS are growing in Australia, however, little is known about factors supporting their implementation. So we sought to find what the factors are. So we did this study to determine the facilitators and barriers for implementing MAPS in Australia from the perspectives of services that have implemented or have tried to implement a MAPS model at their service. So our study was set across Australian maternity services that had implemented or considered implementing a MAPS model. We involved metropolitan, regional, and rural settings, and a lot of the MAPS models in Australia are from New South Wales, particularly in regional and rural areas. We did a qualitative descriptive study, which was guided by the Consolidated Framework for Implementation Research, also known as CIFA. And we used Teams or Zoom interviews with maternity service managers and clinicians to find out their perspectives on MAPS implementation. And we analysed the data using the CIFA framework to frame our findings. So we have our participants here. We were able to recruit 17 midwifery professionals. 6 of them were midwives or clinicians at the time. 4 were managers. We had 4 maternity service leaders, a clinical director, and a clinical midwifery educator. As stated before, New South Wales is the leader in MAPS implementation, and as such, that was reflected in the number of participants from New South Wales. We had 8 participants from there. We had 4 from Victoria, and then 3 from Western Australia, and then 1 from South Australia, and 1 from the Northern Territory. We did try to obtain participation from individuals in Queensland and Tasmania, but according to our research, it was identified that there were no functioning MAPS in these areas. However, it could just be that the people we spoke to were not aware of this. However, we think we've had a good representation across the country. The majority of participants were from services that had implemented a MAPS model. So we had 13 participants from there. And we also had 3 that were considering MAPS. And we had 1 individual who was employed at a service that had considered MAPS in the past, but they didn't actually go ahead with implementation. So the CIFA framework is constructed in a range of domains. They have inner setting domains, which refers to the inner setting or the health service itself. And it also has the outer setting domain, which relates to factors that are going on outside the hospital service. And within those domains, there are a number of factors that are looked at. So as you can see here on the slide up the top, we have the enablers from the inner setting and also the barriers or challenges. I'm not going to focus too much on the barriers or challenges today because even though they were considered as something that had an impact on implementation, the majority of them were overcome with various strategies. So I won't go too much on that, particularly in the interest of time. So in terms of the source of the innovation, so who developed these MAPS models at the various sites, many of them were by MGP model managers, and this was seen as really valuable because MAPS is quite similar to MGP. So having that infrastructure or an individual with that experience was seen as a real key enabler to implementing a MAPS model. In New South Wales, they had district teams of health services working together to implement MAPS because the government had a strong focus on doing so and provided funding to support that. Having an implementation project manager, so an individual specifically responsible for implementing MAPS, was a key enabler. It meant that this person started from the beginning, so developing the implementation plan and stepping out how everything was going to happen to the actual point of implementation and within the first few months of implementation to make sure everything was going well. Many of the sites didn't have this luxury of this role, and midwives were doing it on top of their clinical duties, but all sites mentioned that they would have loved to have this specific dedicated time to work on implementation, and they felt that would have led to the most efficient and sustainable approach to implementation. In terms of the evidence base to support implementation, many participants referred to Sandel et al.'s Cochrane review about the benefits of midwifery continuity of care models. A lot used benchmarking data such as this wanting to reduce cesarean rates or rates of intervention. The New South Wales birth trauma inquiry was another factor that was used as a source of evidence to promote MAPS implementation, because a lot of the women who provided submissions to this report suggested that continuity was something that would be really beneficial to them and could potentially prevent birth trauma experiences. Seeing other sites having MAPS models and how well it was working as a guide was also a key enabler, and also alignment with policy frameworks for improving woman-centered care, as well as consumer expectations for wanting continuity. In terms of the advantage of MAPS, many participants indicated that they considered it to be better than standard care. It was kind of seen as the middle point between standard care and MGP. They all recognised that MGP would be ideal, but in the context of workforce issues and trying to attract and retain midwives, they felt that MAPS was possibly a good strategy for supporting the workforce and providing some continuity to women in the community. They wanted to increase midwife work satisfaction. They wanted to have less reliance on a medical workforce, which is also in great strain in Australia, particularly in rural and regional settings, and wanting to provide community-based care and greater efficiency in the type of care provided. The model was considered adaptable because it has a flexible design, particularly when midwives are managing their own caseloads, as you would expect in MGP. And that was seen as the best model to have, where midwives are managing their own caseloads and managing their own work-life balance to ensure flexibility, but also maintaining a high quality level of care. Sites where they were able to trial the model identified that that was really an important enabler and helped them to refine the model over time. So they started with small pilot testing with a small group of women, and then incrementally increased the caseload over time. And some sites did it by piloting with small population groups, such as, culturally and linguistically diverse women, or women with who are experiencing high levels of social disadvantage, just to trial it with groups that would really benefit from having that continuity, but also really managing the size of the caseload. In terms of the design, it was important that the model ensured that it provided continuity, so true continuity. There were some reports that indicated that they tried to develop the model in a roster-based design, and that really didn't work very well for continuity, and thus having a caseload kind of approach was seen as more appropriate. Many of the sites, or all of them, said that the model was actually cost neutral, so it didn't cost any more or less than the previous standard care model, though there was some evidence at some sites that it was actually cost saving, and this was another driver that led to sustained implementation. In terms of the outer setting, things that prompted implementation were critical incidents such as loss of GP obstetrician, having the opportunities for midwives to become endorsed so that they could provide a greater scope of care. Safety concerns at some sites who went through an external review by particularly in Victoria, demonstrated that that was a strong impetus for implementing a MAPS model, because their prior model was not working as safely as it could be. Having medical staff involvement was a key enabler. Having local health district support, as well as the birth trauma inquiry findings, prompted many services to implement a MAPS model. And particularly the New South Wales Health Continuity of Care Models, a Midwifery Toolkit was often mentioned as an important resource for supporting implementation. And having targeted funding to employ a dedicated implementation manager was seen as a really strong enabler. In rural and regional sites where services were at risk of closure, having community pressure to maintain service delivery and engaging the community was a strong force for ensuring that they consider their redesign of models of care and implement a MAPS model to meet the needs of both the workforce as well as the women in the community. Um, and seeing successful implementation at other sites and having difficulties recruiting to MGP positions was often a driver for implementing MAPS as a strategy to overcome these issues. In terms of infrastructure, so some sites mentioned that having clinic space was an issue for implementing a MAPS model because they needed more midwives to deliver care and thus they needed more space to deliver it. Many overcome that by doing community-based clinics. So if they had access to satellite sites or community centres where they could deliver care, that was seen as an enabler. There was one site that they provided care predominantly in the home, so they went to women's homes, and thus there wasn't a need for more space at the hospital site. Many sites developed digital tools to support practice, and often these came from if they had access to an MGP model, using their tools was really supportive, and also having telehealth capability was also a strong enabler for overcoming space issues. In terms of work infrastructure, majority of sites reorganised the full-time equivalent positions that they had in the previous standard model of care to fit in with a MAPS model. There were some sites that had to recruit more midwives, but that wasn't always the case. Having specialist midwives and midwifery leadership to support implementation, as well as support of medical practitioners, was also seen as a key enabler for supporting practice. In terms of some of the barriers from a staffing perspective, not having that implementation manager or having a lack of an appropriate skilled leadership. Often having a strong midwifery leader was repeatedly mentioned. Not always necessary, but someone with an awareness of how midwifery continuity of care models work was seen as really important. In terms of relational connections, key enablers for implementing the model was to ensure that relationships within the service were managed effectively. So there were some reports where sometimes a bit of an us and them kind of thing happened in terms of the standard care midwives as opposed to the MAPS model midwives. So ensuring that there's clear and transparent communication about how MAPS works is really important to avoid those kind of tensions in the workplace. Having supportive administrative teams. So some participants suggested that often the administrative teams weren't engaged in the planning and preparation for MAPS, and that brought about issues as they were unaware of the expected processes needed to onboard women and deliver their care. So they indicated that including administrative teams in the planning was really important, and having supportive executive staff and leaders at the site where they didn't actually go along with implementing MAPS. The key factor that was an issue in progressing with the implementation was obstructive leadership. So having keeping executive leaders on board and giving a strong case as to why this model would work and is important was really considered an important enabler for implementation. all of the services said that they wanted to implement this model from a human equity perspective, to ensure that more women are having access to continuity of care, to support high risk populations, and also to provide free services to women. And this is a specifically an issue for rural sites. So women who go to rural services in Victoria often have to see a GP obstetrician, and that comes with a lot of high, out-of-pocket costs. But once the sites implemented MAPS, the care was midwifery-led, and thus this really reduced the cost for women, as that midwifery care in Australia is predominantly free. And a lot of the rural sites also expected that their midwives become endorsed, and that also expand their scope of practice and also expand the amount of free services that women could receive. In terms of deliverer-centeredness, this was another key aspect of driving implementation. So focusing on midwife needs, by improving their work satisfaction and developing a model with the flexibility that they would like, and also ensuring manageable caseloads. There was some well, it didn't come from our study, but previous studies in MAPS have shown that when the caseloads are too high, it runs the risk of burning out the midwives, despite the more flexible type of model. So it's really important having a staged process for determining the caseload for the midwives, depending on the population. So, for example, if the midwives are working with a more vulnerable population, a smaller caseload is important, as opposed to midwives that are working with, lower risk women. Number of factors related to learning centeredness, such as access to training to support practice, having opportunities for midwives to become upskilled in various areas, and achieving endorsement. And one key strategy was ensuring that midwives were involved in regular case meetings, supervision, and feedback sessions, so that they could talk through, particularly in early implementation, about how they were feeling their model was going, if there were any issues, and having those open and frank conversations about caseload and any other measures that need to be put in place to ensure the well-being of midwives as well as women. In terms of the implementation process, there were often the sites that implemented, there was a strong tension for change. So that risk of their services being closed, or workforce pressures, or having to reduce cost, was a reason for implementing MAPS. Having the model being able to fit in with current systems and policies and procedures was also seen as valuable, and this was MAPS was easier to implement at sites that had MGP. Having strong incentives for implementation, such as sustaining maternity service delivery, recruitment and retention of midwives, and improved care satisfaction, were really strong drivers for implementation. Cost savings were not considered as a driver for implementation, but they were a nice kind of outcome for many sites, where they saw that they actually reduced the cost of service delivery. I spoke about available resources, but having a strong business case and implementation plan that is staged with what's going to happen at each point of time was seen as an important strategy to support effective implementation. Some sites used supplementary funding sources to support their models, for example, from philanthropic organisations, and if their hospital was linked to a particular a philanthropic fund, and this was often used to support the purchase of additional clinical tools, such as clinical bags for going out to women's homes, or scales, or whatever that was needed. They were seen as an important enabler. I've spoken about space before. And another point of tension was access to fleet vehicles. So within this model, Midwives often drive out to women's homes, particularly for postnatal care, and having access to fleet vehicles was seen as a useful enabler, but there were some sites where this was not possible or financially feasible, and they asked midwives to use their own personal cars and developed policies around that. However, it was a point of tension with the midwives not liking the idea of doing that, but the participants did say that over time that came used to the idea and it all worked well, but ideally having fleet vehicles would be the best way to do it. In terms of knowledge and information, building awareness of maps both within the sites as well in the outside community was seen as an important factor. Having access to courses to skill midwives as well as access to individuals who have implemented maps. So, in terms of the implementation plan and evaluation, important enablers was having a strong business case, a comprehensive staged implementation plan, but most importantly, having the time to implement. So, some sites had very little time, particularly if they had to align with a certain set of funding that was given by the government. So they had to rush through to meet those funding deadlines, and that brought about challenges. They still achieved implementation, but it wasn't as smooth or as efficient as they would have liked. So having at least 6 to 8 months before going through, full implementation was seen as an important enabler for ensuring that everything was thought through properly. Allowing time for negotiations with relevant bodies such as unions and any other important bodies that play a role in the nursing and midwifery workforce. Participants mentioned that this took a lot more time than they expected, and this often delayed implementation. So ensuring that there was adequate time for that in the plan was indicated. In terms of evaluation, so how were sites evaluating the model? They looked at women and staff satisfaction surveys. They were looking at workforce data, so workforce retention, workforce sick leave, workforce vacancies, and so on. They looked at clinical outcomes and length of hospital stay data. At rural sites where they were at risk of closure, activity data was really important. So how many women were they bringing into the service? And most of the rural sites had a rapid increase once MAPS was implemented. They were shocked with how many women were coming along to the service. Measuring continuity, so how often women were seeing their same midwife while receiving care in the model. And some sites were also looking at cost effectiveness. So here are some quotes from our participants. So the first participant said, MAPS is kind of seen as that, silver standard care to the MGP model gold standard care, but it's still better than routine care. They wanted to be able to give all women continuity in our district when they launched, and they did that by introducing MAPS and MGP. And this was mentioned very often from the participants. They wanted to give women continuity. They knew that MGP is the best approach, but given all the other factors that impacted that, they thought MAPS was a nice kind of go-between. The importance of a funded implementation manager is reflected in the second quote. I don't know who funded the project officer. She's been given that role to implement a MAPS model at our hospital and a MAPS and an MGP in our district. She had done the same thing at another site a few years before, so she was obviously very educated and knew what she was doing. The third quote reflects the importance of trialing MAPS in small groups and then building on it over time. So this participant said, They started booking really slowly. I think they started booking 3 women a month. We kept them at 5 for quite a while just to work out what was going on. And then so this is on zero point 0.5 full-time equivalent. So for a full FTE, it would be 10 women a month. And then we decided, let's just have a look and push and see what it does. And we took them to 6. And this is where we've landed. They're happy, the women are happy. We've just left it at that. So that seems to be our sweet spot here. And finally, our participants talked about the cost effectiveness of the model. She said it would definitely be a cost saving. I just set up to at least 20,000, but in fact, it's probably closer to 30,000. And I need to sort of crunch the numbers a bit closer to now that we've been 6 months in, but it certainly hasn't cost us any more. So, in conclusion, effective MAPS model implementation requires informed and supportive leadership, stakeholder buy-in, and appropriate resources to ensure models meet the needs of women, midwives, and maternity services. Implementing MAPS has the potential to improve midwife job satisfaction and expand women's access to continuity of care, supporting workforce retention and sustainability of high quality maternity services. And this was very much reflected in the participants' feedback in our study. So thank you for your time. There's mine and Linda's email address if you'd like to get in touch about this study or any other work we've done. And you can also search us on LinkedIn. We're both on there. Thank you.
Thank you so much for sharing this important and timely research. So there has now an opportunity for questions. So you are welcome to put them in the chat, or you can raise your hand and we will be able to unmute you so that you're able to ask your question. Jenny has posted a really good feedback from the area in which she's working in Queensland that you had mentioned earlier, commenting on how a number of remote services in Queensland, which can include models within First Nations communities, provide midwifery antenatal and postnatal services where there are 2 midwives supporting each woman, and then the women travel the extensive distance to the hospital where they birth. For those that are joining us that are outside of Australia, we are very geographically diverse with a number of services that are located in very remote areas. So long distance travel can be required to be accessing the closest birthing hospital. Have you heard of these amongst your research and your background research, Vidanka, the services that may be more dispersed across Australia and Queensland particularly?
Yes, as I said in the presentation, we reached out to a few people in our networks in Queensland to ask about their awareness of MAPS models, but they weren't aware of any. But I'm not surprised that there is some, particularly in the remote areas, because we did speak to a participant who was from the Northern Territory who was working in a similar amazing model, with a lot of challenges in terms of the terrain and distance and so on, but they managed to overcome them with some astounding midwives supporting the care of these women. So I will definitely look out for work that's been happening in Queensland. Who was the person who said that comment?
Jenny.
Jenny. I might Jenny, if you've got any contacts who works in that area, I'd like to know about them. So if you could give me their emails, I would really appreciate it.
We haven't had any more questions. We'll give another minute in case anybody has anything that has come forward, that has come to their mind. It's been really interesting to hear of your research, and I know that particularly in Australia, this is an area that is starting to expand in both the implementation of these models and the research surrounding them. So it's been really great to hear what the midwives are saying from your research. So thank you so much for sharing.